This is a continuation of Learning Plan 1. This is about where we left off when I finished up the last recording. So we just kind of talked about prevention strategies, primary, secondary, and tertiary. So back to the case study of Edgar. Edgar's diagnosed with major depression and post-traumatic stress disorder, which we call PTSD. At the team meeting, Edgar describes some of the struggles he's had with this disorder since returning home from the war. He agrees with his wife Annie and his team that while they will work on treating his current symptoms, they will also collaborate on preventing its progression to a more severe level so that it doesn't become disabling or lead to suicidal ideation. So an audience response question: what type of prevention is Edgar's team most focused on? Primary, secondary, tertiary, or it's too late for prevention, Edgar already has a depressive disorder? So I'm hoping that you didn't pick D, and actually it's a little bit tricky to figure this out, and I won't ask you tricky questions, or at least I don't think they're tricky on the exams, but secondary prevention is what they're most focused on, which is treating him currently, here and now, for his symptoms. Tertiary is more of the focus on prevention of relapse for the future, which it sounds like was also part of the planning. But truly, I think this is a little bit of a trick question because some of their approach is secondary and some is tertiary. Anyways, let's keep going on. So the needs of outpatients. So when we discharge somebody, we have to think about what are we discharging them to? What type of situation and where are they going to live? There are many people that we discharge that are homeless. Perhaps they're going to a shelter. Maybe they don't have a home of their own, but they're living with either friends or relatives. And, we always want to take a look at if that's a good situation or not. But we also have to realize that people are adults and we can't make choices for them. Even if we see them being discharged to a situation that we really don't feel is very helpful for them, we certainly can talk to them about it, but there is nothing that we can do to force them not to go into that living situation that we don't really think is the best for them. So this comes up quite a bit on 1K when we see people forming friendships and relationships, and then they want to go and live together after discharge. And many times that really doesn't work out very well. However, we can counsel the patient and maybe talk to them and encourage them to focus on themselves and their own health and wellness and not to live with another patient. But in the end, it's really their decision. So that is one thing, is where are they going to go and who are their support systems? If somebody that has say problems with alcohol or addiction, if their discharge plan basically is to go back to their friends and their support systems, but all of their friends and support systems use, then that's not going to be a really good solid discharge plan for them. So the problems that may affect the success of their treatment certainly would be sometimes things fall apart when people leave the hospital. So they don't have a good place to live. There's no stability. They have friends that are perhaps detrimental. Perhaps they don't have enough medication or money to buy their medication. There's lots of things that can kind of fall apart once people leave the hospital. We can also think about many practical problems that people might have. Maybe we have outpatient counseling set up for them or other types of appointments, but maybe they don't have a way to get to those appointments. So lots of different things to think about, but really truly where they live and their support system is absolutely huge. When patients don't have any type of support system, that also is something that we need to take a look at and see if there is anything that we can do to help with that, because that truly will affect the success of treatment, and they will not have very positive outcomes if we're not looking at the environment into which they're being discharged. So settings for inpatient care: crisis stabilization observation units, that might exist in some hospitals. It does not exist at Sheboygan Memorial. That would be a situation where they would have specific beds in the emergency room that are strictly for observation, that the person isn't admitted to the hospital, but they're keeping them there perhaps for a day or two for perhaps some intensive treatment and for observation to see if their symptoms are going to get any better, and then perhaps they can just hook them up to some resources and discharge them. Or perhaps if they're not getting better, they may end up in the hospital. But we really don't have that in Sheboygan, and Manitowoc actually does not even have a mental health unit. So all of the patients that are Chapter 51s from the Manitowoc area, and actually several areas around us, other counties also have a contract with Sheboygan Memorial for hospitalization. So that might exist in some places. Having a general hospital or private hospital have a psychiatric unit or psychiatric beds, again, very typical, something that we do have here in Sheboygan. They do not have that in Manitowoc. Or there could be those state hospitals that I was talking about before when we think about people being institutionalized. They're in usually huge hospitals, and there really aren't very many of those left in the United States. And a state hospital usually is long-term, and a general hospital or a private hospital is usually more short-term acute treatment. So how do people get into treatment? They may be a direct admission, they may be referred from their doctor, they may be referred from their therapist. People can enter the hospital themselves. They can have themselves admitted. Of course, they need a doctor to admit them, but any person can come to the emergency room and say, I would like inpatient psychiatric hospitalization. They're certainly going to do a thorough assessment because perhaps that person isn't acute enough to be in the hospital, and then in that case they would try to do a safety plan and get that person some immediate help and some resources. You do have to meet criteria in order to be in the hospital. So you really do have to be a danger to yourself or others, or mentally to the point where you are not able to meet your own basic needs. So again, emergency department, so you can either be brought to the emergency room by a friend, a family member, by the police. You can bring yourself to the emergency room, and you can be either voluntary or involuntary. So involuntary really is that you are there against your will. You did not choose to come to the hospital, but there are many patients that do voluntarily come to the hospital. So patients' rights. Hospitalized patients retain their rights as citizens. So that is very important to remember. Just because they're in the hospital against their will, they do not lose their rights as a citizen. So people come to the hospital voluntarily, and of course they retain their rights, but even if they don't come voluntarily and they're committed, that still does not mean that they lose their rights as a citizen and as a person. So the patient's need for safety has to be balanced against the patient's wishes as a citizen. So there are some times when rights are denied, such as telephone rights, or perhaps the right to have some of their belonging or their clothing if they are an escape risk or a suicide risk. Some of those rights may have to be temporarily suspended. And mental health facilities have written statements of patients' rights and applicable state laws. So when you get to the point of being in clinical, you will notice that there is a statement of patients' rights that's pretty much right in the up at the nurse's station and easily seen by the patients. Teamwork and collaboration. So that's part of CUSIN, of course. We do work with a lot of different types of team members in the mental health area. There are psychiatrists, there are mental health counselors, and all of them have different degrees. Some of them are social workers, and some of them may have degrees just in counseling. One person is a psychotherapist. There are occupational therapists that provide the activities therapy. There are two of them right now, and both have an occupational therapy background, and they are assigned to the unit. They don't float around the hospital and come to our unit to do groups. They're actually assigned as part of the team to our unit. We don't have psychologists, but we do have psychiatrists. We have nurses, nursing assistants, unit clerks, and even housekeepers have to kind of be part of the team because everyone's observations can be, and communication with each other can be very helpful, especially when there's an issue with a patient or a patient becomes suicidal or makes an attempt. Maybe it's the housekeeper that's going to walk in and find somebody. So we all have to really work very, very closely together. There are times when the roles might just overlap a little bit, but usually they're pretty well delineated. So members of each discipline are responsible for gathering data, participating in the planning of care. Treatment plan or clinical pathway provides a guideline for patients' care during the hospital stay. So there are clinical pathways for different diagnoses. If somebody comes in and they are manic, if they're depressed, if they are going through drug or alcohol withdrawal, if they're suicidal, there's different clinical pathways that they try to follow. The nurse's role is really to lead the planning meetings and to really offer the expert 24-hour observation of the patient because no other discipline is there 24 hours. And for standardizing the treatment and improving outcomes, again, we use clinical pathways. I'm guessing they're also used in med-surg units. The therapeutic milieu. So this is a really big focus for mental health nurses. And I will also talk about this again when we get to clinical. And I will probably ask you during clinical, during post-conference, to think about any milieu influences that you observe during your time on clinical, because there should be plenty of things to observe. So the milieu, it's a French word really meaning the surroundings and the physical environment, but it's not just the physical environment, it is also the emotional environment. So if staff are fighting with each other, not getting along, not working well together, things like that, that's definitely going to affect the milieu. And sometimes the conflicts, if staff do have conflicts and they're really kind of evident and everyone can see that people are fighting with each other and not getting along, that does spill out into the milieu and affect the way that the patients are feeling. It makes them anxious to see their caregivers not getting along, not working well together. It can increase their acting out. So we really do have to make sure that everything about the milieu is therapeutic, and that is absolutely the job of the nurse. It's not that other disciplines like the mental health counselors, the social workers, psychiatrists, occupational therapists, it's not that they don't pay attention to the milieu or interact with it, but really it's the nurse's role to make sure that the milieu is therapeutic. So an example, if a patient is really upset and they're at the payphone, which we don't have phones in rooms, so there's just like 2 payphones out in the hallway and one in a small kind of room that the patients can use. It's pretty evident if a patient is screaming on the phone and slams the phone down, that's going to affect the milieu. Or if the patient starts saying something really inappropriate on the phone, which I have observed before. There was a patient once who had very poor, I guess just really poor judgment, and he was talking to his very hard of hearing grandma on the phone, and he was starting to describe in detail his sexually assaulting a small child. And so I stopped him immediately from talking because I could see other patients were starting to listen to what he was saying because his grandma was hard of hearing, so he was talking pretty loud, and what he was saying was absolutely sexually explicit and very inappropriate to be saying on a phone in a public area like that. So we have to put a stop to things like that when we see them happening. There's lots of different milieu influences, and we'll talk about more examples when we get to clinical. But so part of the milieu is not just the physical environment, it's the way that staff are interacting with each other, it's the way that staff interact with patients. It certainly can affect the milieu when patients are not getting along with each other, and perhaps they're fighting or they're just in conflict. It can make the milieu a very tense place to be. And it could even be extra commotion or noise on the unit related to construction. This actually happened a few times, actually many times over the last few years, because they've been doing a lot of different changes on 1K to make things a little bit safer. But there was one day not too long ago that that some workers were fixing the door to the medication room. They actually had to remove the door completely and fit the new door in, and they said it was only going to take a couple of minutes. Well, it took about an hour and a half, and it was extremely noisy. Many drill sounds. They measured the door incorrectly, so they had to take the old door away, bring the new door back. They tried to put it up, and it still wasn't working. They had to saw some of the door off, and it was just really, really noisy. And at one point, it almost sounded like that dentist drill sound, you know, that really loud, kind of high-pitched, annoying sound that the dentist drill. And I thought, boy, if that doesn't trigger somebody as a milieu influence. So it was really difficult to, to be relaxed and not feel any anxiety when all that was going on. There have been other times actually when the unit has been kind of permeated by different smells too, based on construction being done in the building. If all of a sudden you smell just like a really strong odor, like an electrical smell or something like that, or a chemical smell, that also can affect the milieu. Think about it. If you were paranoid and you thought somebody was poisoning you or following you, then you might really that might really trigger, some thoughts. You might start to really fear for your safety if you're smelling something odd, or if you're hearing some odd noises and pounding and sawing and things like that. So safety features certainly are part of the milieu, and again, in clinical, it'll be easier to kind of point some of those out. And they have done a lot of safety changes on the unit lately with different types of doorknobs, different types of bathroom doors, closing off the bathtub room completely. So it's really been kind of interesting over the last few years. Just the overall design of the unit. Really, truly, 1K was not designed with it being a mental health unit. It was not in their mind when they designed that unit. So actually that layout of the floor really is not terribly conducive. I think when they build the new hospital, it probably will be a lot more conducive to having a more therapeutic, relaxing milieu. I even heard that there was going to be some type of inner courtyard which is going to be enclosed so that it would be a safe place for people to actually go outside and get some fresh air. So again, the milieu is something we manage. There are so many different aspects to the milieu, and we all have to really watch our behavior when we're out in the milieu, because we don't want to add to the chaos of the milieu. So inpatient psychiatric nursing care. We complete comprehensive data collection, includes the patient, family, and other healthcare workers. We develop, implement, and evaluate plans of care. We assist or supervise mental health care workers. We do have some units have what they call psychiatric technicians. We don't really have those at Sheboygan Memorial. However, I have worked with those in other types of places, and basically they have a bachelor's degree, usually in psychology or something related, but they are still considered paraprofessionals because they don't have a nursing degree. So there might be some times where we have to provide them with some feedback, and certainly nursing assistants need some feedback because they're oriented quite well to the unit, but they're really not well versed in therapeutic communication and other aspects of a person's illness. They don't really understand schizophrenia or bipolar disorder. We maintain a safe and therapeutic environment. So Usually nursing assistants are doing 15-minute checks on patients. However, when you are there for clinical, you'll be doing the 15-minute checks. But it's up to the nurse to kind of monitor and make sure that those are getting done. That's part of the therapeutic and safe environment. Of course, the best way to maintain anyone's safety, think back to Hildegard Peplau, is that relationship that you form with the patient. So that's really the best way to keep somebody safe. But there are things that we have to look for in the environment. If we see any hazards, we need to take care of those right away. One thing that comes to mind is that there are patients that need CPAP machines at night. And yeah, those are pretty dangerous. Just think about the cord and the long coil, that could easily be used for choking themselves. But they are allowed to use those if they need those. I mean, it's certainly very important to their overall health and their sleep if they're using a CPAP. But the CPAP needs to be taken out of their room and stored in a secure closet as soon as possible after the patient awakens. There are times when we're passing our 8 o'clock meds or 9 o'clock meds and we're still finding CPAPs in the room that nobody bothered to take out of the room when the patient awoke. So, lots of different things that we have to do with safety. We also contract for safety with the patient. We ask them to remain safe, and if anything were to change, that they would let us know or let somebody else know, that they promise not to hurt themselves or hurt somebody else for their particular shift, and that is usually done on a shift-by-shift basis. So that safe and therapeutic environment, facilitating health promotion through teaching. Many times our patients don't have really good health habits. So not only do many of them abuse drugs or alcohol, many of them smoke. Caffeine, excesses of caffeine is really a huge problem. And unfortunately, patients can order up to 9 caffeinated beverages on their meal trays per day. That's an awful lot of caffeine. So we really probably shouldn't be allowing that, but it's always good to provide some teaching. We always are monitoring their behavior, their affect, their mood, maintaining oversight of restraint and seclusion when those do occur, and just, again, coordinating care by the whole treatment team. Everybody really needs to be on the same page, especially when a patient has mania and perhaps they're trying to staff split, or if somebody has a personality disorder and they're trying to staff split, or to get certain people to give them privileges but nobody else gives them the privileges. And if people aren't working together, that can really kind of create a chaotic situation in the milieu. So nursing really kind of is the one to keep tabs on all of that. So this is similar to what other nurses do in other areas, but some of the actual interventions are just a little bit different. So they're just much more psychosocially oriented than physically oriented interventions. But anyways, so we just kind of covered some of the basic role of the nurse in an inpatient setting. And again, it'll be more apparent to you when you actually are in the clinical setting. So an audience response question. After a suicide attempt, Edgar tells the nurse, "I need my belt to keep my pants up. They keep falling down." Which response should the nurse provide? "Your belt is locked in the business office for safekeeping along with all your other valuables. For safety reasons, hospitalized clients are not allowed to keep certain personal possessions. I cannot provide your belt, but I will help you get some pants with an elastic waistband. Or I will ask the psychiatric technician to get your belt for you." So I'm hoping, now A and B aren't horrible responses, but you're just basically telling the patient the rules and you're not really offering them to help them with their problem. So actually C is considered the most therapeutic. Certainly D would be not appropriate because if Edgar made a suicide attempt, we certainly don't want to give him a belt. That would just be not a good thing to do. Definitely against policy. Belts are not allowed on the unit. The only thing I do have a little bit of a problem with C would be with the elastic waistband, but they do, because they do have those paper pants on the unit that many of the patients wear, and there is an elastic waistband in there. However, the paper pants are really pretty thin. You can actually easily rip them and get that elastic waistband out, and that would be something that would be very strong, and a person would be able to hang themselves with that. So personally, I don't really think that that's the best alternative. They sometimes use patient ID bracelets, and they hook a couple of their belt loops and, kind of tie the ID band around a couple of belt loops just to cinch the pants in a little bit tighter. That seems to work, especially if somebody has jeans on and we really can't give them a belt. But yeah, the elastic waistband, that's really, I know that's the best response here, but it's not always the safest thing. But they do allow them on 1K, at least at this point in time. So anyways, enough about that. Specialty treatment settings. So I actually worked on a geriatric and neuropsychiatry specialty unit a long time ago. That was a very interesting job. There are pediatric psychiatric units. We actually have a adolescent unit on 1K. However, it's been closed for a few months now because they need to find a new pediatric or at least adolescent psychiatrist. We never had children. 12 and up would be considered an adolescent, and that's the age range that we took. So hopefully we'll have that up and running again. But if anybody is under 12 and needing hospitalization, they would have to go to a bigger city such as Milwaukee or Green Bay. But there are units that are available for children. There are geriatric psychiatric units. And again, I worked on, it was a combination geropsych and neuropsych unit. There are veterans centers, forensic psychiatric care for people that have committed crimes when they have been mentally ill. Perhaps they've committed murders, robberies, different types of violent crimes. There are alcohol and drug abuse treatment settings and maybe specific treatment units. There are also lots of self-help options out there as far as people getting treatment. Self-help groups. In Sheboygan County, we have Mental Health America, and they do have a lot of self-help groups for people. But of course, that would be when they're more stable and they're in an outpatient basis. The other type of specialty treatment setting that's not listed here is, I believe, in Rogers Memorial Hospital, at least in one of the Rogers hospitals. I think there are a couple of different buildings. They actually have a unit just for patients with eating disorders, so that would be like a subspecialty unit. And I believe they also have a specialty unit for people that have obsessive compulsive disorder, because you really have to work just in really specific ways with people with those specific types of disorders. So it's much easier to have them all on one type of unit. Chapter 5, Cultural Implications. Okay, so Western tradition, that's us. We find our identity in our individuality. We are just so proud to be our own individual self, our own person, following our own path, lighting our, blazing our own trail. Those are all things that are kind of important to us in our culture. So we value autonomy, being independent, self-reliance. Those are all things that we feel are really very, very important. So mind and body are separate entities. I kind of disagree with that a little bit, because I think we're learning more and more, and especially in the areas of mental health, that the mind and body really isn't separate and that the two work very closely together. So an example would be when somebody has anxiety issues that are psychologically based, there are physical symptoms. So you really can't separate the mind body. So I kind of disagree with that one, but that's what the book said. We feel that disease has a cause and the treatment is aimed at the cause. For us, time is linear and success is obtained in preparing for the future. So how many times do we tell you, if you're a young adult, how many times have you been told, start planning for your retirement right now? It's like, well, maybe you're thinking you're kind of young and you don't really want to do that. Maybe perhaps if you're a little bit older, you may have already started thinking about that, but that is something that we we kind of think about that, preparing for the future, making sure that we have the resources that we need when we age. Eastern tradition is more family-based, so the family is the basis for your identity rather than your own individuality. The body, mind, spirit is considered one entity. Time is circular and reoccurring. You're born into a fate. It is your duty to comply with that fate, and disease is caused by fluctuations in opposing forces. So if any of you have a background in Eastern tradition, that would be really awesome to hear from you and to hear your perspective as to how that affects your beliefs about healthcare and health and illness in general. The indigenous cultures, they place significance on the place of humans in the natural world. The basis of identity is the tribe. The person is an entity only in relation to other people. And disease is a lack of harmony between the individual and the environment. So American Indians might be one example of this, or possibly Alaskan Natives would be another example that I can think of an indigenous culture. So the impact of culture on mental health, really quite interesting. I hope that you have the opportunity to work with people of different cultures, because there are so many different ways that different behaviors are viewed by cultures. Some things that we would consider mental illness, another culture may not consider it an illness, and vice versa. Some things that they consider illness, we might consider to be normal behavior. So we're going to go through some of the definitions here on the slide. So enculturation is really that process by which members of the culture learn what's right, what's wrong, what's acceptable, what's not acceptable, and usually that comes from your family. So as children, we learn from our parents which behaviors, beliefs, values, and actions are right and which are wrong. So the individual is free to make choices, but the culture expects the choices to be made from an acceptable range of options. So there are certain ways that we are taught that we are supposed to act. And that's important in every culture, no matter what culture you come from. Deviance from cultural expectations can be defined as illness by other members of that group. Ethnocentrism is something that we experience sometimes in our American culture, and that is that we think our culture is the best and that other cultures are somehow inferior to us. So if we have feelings like that, I think it's really helpful for us to identify it and work on our attitudes and work on communicating so that we do not communicate that to another cultural group. So it's probably good for us to do some self-awareness and really understand why we feel that way, and that it really is not helpful in healthcare when you're working with somebody from a different culture. And then cultural imposition kind of goes along with that ethnocentrism, is that you feel like whatever you are doing is what everybody should be doing. So we try to impose our cultural values and beliefs onto other people, even if that might disagree with, where they come from with their own cultural beliefs and values. So a really good phrase that I can think of that exemplifies this would just be that you hear people say sometimes, well, they're in America, they should speak English. They should not be speaking Spanish, they should be speaking English. If they're in America, they need to do things the way the Americans do them. So that would be imposing our cultural values and beliefs and practices onto somebody else who comes from a different culture. On page 81 in Varkarolus, there's a really nice example of some of what I was just talking about. The same thoughts and behaviors considered mentally healthy in one culture can indicate mental illness in another. For example, some religious traditions view speaking in tongues as mentally healthy and a gift from God, whereas a different culture might consider this same behavior as psychosis and a sign of mental illness. Okay, so barriers to quality mental health services. So first and foremost, of course, is communication barriers. It is really difficult to give people really good mental health care when there is a communication barrier. Even if you're using a translator, it still can be really tough to get to their thoughts and feelings. We might not even be able to formulate the question in the right way for them to understand what type of response we're looking for. So it really does get quite tricky. There are personal translators that sometimes come to the unit. I've seen them come to one case several times, and then there are also phone translators that can be accessed, especially if somebody speaks a language that is just not a common language in our area. So at Sheboygan Memorial, basically the two languages that I see the most often would be Hmong and Spanish. So there are people that can come to the unit that are fluent in both of those languages, but there are times when we've gotten patients that speak Albanian or something really different that we don't speak, or Dutch, something that people around here don't really speak. So just getting through that communication barrier really can be quite difficult. That stigma of mental illness. In some cultures, it is just absolutely shameful, and you can't even discuss mental health or mental illness. It's not something that is people are in some cultures are very open about and accepting of. So very difficult to teach them about their illness, very difficult to have them accept any type of Western medicine because of that stigma. There can be a problem with misdiagnosis. On page 83 in the Varkarolus, they talk about that there are several cultural groups that actually are prone to get incorrectly diagnosed. African American, Afro-Caribbean, Latino, Hispanic Americans run a significant risk of being misdiagnosed with schizophrenia when the true diagnosis is bipolar or another affective disorder. And they're feeling that that misdiagnosis happens because we're using culturally inappropriate assessment tools. Your book also talks about misdiagnosis happening because in some cultures, people, instead of talking about their feelings of sadness or depression or stress or anxiety or any of those types of things, they might talk about they somaticize, and so they talk about their bodily issues, and they talk about their aches and their pains and their dizziness, their fatigue, and they're not able to verbalize their feelings of sadness or hopelessness or anything like that. So they might tend to get misdiagnosed because they're not verbalizing their symptoms the way that we're used to hearing their symptoms. Main types of cultural concepts of distress, cultural or culture-bound syndromes. And if you look on page 84, there's box 5.2, and they give some examples of those cultural syndromes, and the explanations. So some of these we really probably don't even hear about. Some of them I actually can't even pronounce. Ghost sickness, I can pronounce that one. Jinn possession, which is Somalian. Ghost sickness is Navajo. Susto is Latin American. So wind illness, Chinese, Vietnamese. So if you look through those, it really is kind of interesting as to what constitutes those different syndromes. I believe running amok is another type of cultural bound syndrome, and actually that has become a phrase that we use often in our own American language to depict when something is really going wrong. Cultural idioms of distress are also very interesting. We actually have some in our own American culture. So when we say things like, I'm a nervous wreck, or another one that has been around for a long time is that when people became mentally ill, everyone would say they had a quote-unquote nervous breakdown. So maybe some of you have heard people use that phrase, what's wrong with them? Oh, they had a nervous breakdown. Well, actually, there's no such thing as a nervous breakdown. So you can look through that whole thick DSM-5 manual of all the psychiatric disorders, and you're not going to find that in there. So, and you're not going to find nervous wreck in there either. Those are just ways that we sometimes talk about and describe our distress. And then sometimes there are cultural explanations for symptoms that are only understood within the context of that particular culture. So other people really would not have any idea what that constituted. There are also genetic variations in pharmacodynamics. The reason that this would be a barrier to somebody getting good quality psychiatric mental health services would be that many of the drugs that are tested on white people of European background, and they're not tested on people of different cultures to see if the medication would be helpful for them. So that can prevent the ability of people with different disorders responding to medications in the same way that other people might be responding. So that is also considered a barrier. Populations at risk of mental illness and inadequate care, immigrants, refugees, and again, cultural minorities. So we may assess some cultural patterns that may support or interfere with the process of health and recovery. What can you do? So I'm going to stop this recording now, and I'm going to pick up with that thought in just a little while.